Hello and welcome to this episode of the ReSPECT podcasts. So we're doing this We're doing this ReSPECT podcast series to try and support staff working across the whole integrated care system to highlight the benefits of ReSPECT, encourage earlier conversations and to ensure inclusion of the multidisciplinary team and support staff to improve their confidence and understand more about the ReSPECT process. That's what I've been told to say, but we're actually going to just have a chat and hopefully everybody will learn something as we talk around the ReSPECT process. So my name's Tanya de Weymarn. I am an emergency medicine consultant and a frailty consultant, and I'm clinical lead for end-of-life care at the ICB, but more importantly, I'm really passionate about the ReSPECT process, and it comes into every aspect of my work. And I've got some wonderful people here today to talk with me. So I'm going to get you all to introduce yourself because I will do enough talking. Go for it.
Hi, my name's Rachel Bucknell. I am a frailty matron at Asper Medical Practice.
Okay. Why ReSPECT?
It's key to everything we do. ReSPECT form, we're working with an elderly population and we need to know what they want and we need to be their voice in an emergency when they can't voice for themselves, and we need them to feel confident that we will always work within their best interests.
Thank you. Jo?
Hi there, I'm Jo Murray. I'm the services coordinator for a charity in Gloucestershire called Guideposts Trust. My role is very much around supporting those living with dementia and those that care for them. The reason that I'm here is because I too feel very strongly about ReSPECT. A lot of my role is community facing, talking to people about planning for the future. We're talking to them about where they might get a Zimmer frame, a raised toilet seat, benefits, and very much the subject that we also need to include that is emergency care planning. And I find that people are hugely relieved to be able to have that conversation over a cup of tea, often away from a clinical setting.
Absolutely. Vicki?
My name is Vicki Howard. I am a clinical programme officer, which sounds quite grander than it is. I'm also the lead for ReSPECT within the ICS in Gloucestershire. I'm really wanting to support the messaging that ReSPECT is incredibly important, the benefits that it can give, and also help staff working in numerous different areas to have the confidence to start these conversations.
Thank you. And you're also here to make sure I don't go on too much or say things I shouldn't say. Okay, so I think we want to talk around there's a couple of things we want to do. We want to bust some myths that people have around ReSPECT. One of the most important things is that ReSPECT is a plan rather than just a piece of paper. So would either of you like to say what you feel about ReSPECT conversations and maybe any myths that you've heard and you've had, or any of you, would you like to say if you've had any myths busted that you thought were correct at first?
Yeah, I don't mind. So we see a lot of patients when they've come out of hospital after an emergency admission, and sometimes they're quite fearful of the form because it's been filled in when they're poorly and they're not feeling very well, or it's been filled in without them knowing, in inverted commas. And themselves and their family quite often think it's the form that's writing them off, that we're not going to do anything, we're not going to send them back to hospital, we're not going to treat them, and we've basically given up on them. So it's about giving them that reassurance and confidence to understand that actually it's not about that. It's about, we want to know what your views and your wishes are in an emergency when you can't voice it for yourself or there's a lot going on, you're too poorly. What do you want? What do you expect? Can't promise that everything you want will happen, but let's get it written down so that there is some expectation on both sides. And I think ReSPECT should be both ways. We need to respect the wishes of the patient, even if we feel that some of the wishes are not in their best interests. We need to lay the groundwork so that, if they've got end-stage lung disease or rip-roaring cancer and they want every treatment available to them, but they don't want to go to hospital. That's a conversation starter. What are their expectations? And more often than not, they just want to be cared for with dignity and respect. They want us to do something, and they want us to be honest with them then when we can't. And DNAR is the very last thing we need to worry about.
Absolutely. I think previously conversations around resuscitation were very paternalistic, with the doctor knowing best. And I think ReSPECT is very different to those old DNAR forms. And I think people are having to learn that actually it's about so much more than that. And as you say, it's a two-way process, or at least a two-way process, and each person involved in that conversation brings their expertise to the table. And whereas the patient or the carer or the advocate would hopefully be an expert in what matters to the patient, we can't expect them to be medically qualified and know which treatments are appropriate. But equally, even though I've been a consultant for quite a few years and I can bring my expertise to the conversation, I am not an expert in what matters to them. And I think it's interesting that often a consultant is not the best person to have the conversation. Do you have anything to say about that, Jo?
Yes, Tanya, I do.
Phew! It would have been disastrous if you hadn't.
And really just to follow up on what Rachel and you've both said is, of course, I come at it from although I am ex-clinical, but very much in this role as non-clinical. And the conversations that I am having with our group members and clients is when we're introducing the What Matters to Me folder. And this is very much, particularly for the carer in relation to the cared for, they are beginning to realise that their lives are never going to be the same again. And there is a real deep-seated need and concern to put plans in place for the unexpected, because very often when we're having that conversation, something unexpected has happened. So, for example, we had a big conversation about the Herbert Protocol with 30-odd people the other week. Somebody'd gone missing. And so it came into planning for the future. That's a brilliant time to ask the group if they have also thought about ReSPECT planning. Yeah. Quite a few of them had been given a ReSPECT form at the time of their cared for's diagnosis, and there are comments like, well, of course, it just made me feel they were writing him off. Of course he wants to be resuscitated. So it comes back to that myth-busting. And I very much see our role as we can reset the conversation. So let's talk about that future planning. Let's think about the pendant alarm around your neck. Let's check you've got the right level of benefits. Let's think about what's going to happen to the dog if something happens. Are you registered with Carers Emergency Scheme? And we never want to think about it. But if one of you goes into hospital, you are now going to be asked if do you have a ReSPECT form. Let's initiate that conversation and just talk to you about the general need for one of these, why it would be helpful, what it might do. And, you know, we can then, very often, we can have a long conversation. And the conversation I had yesterday is, God, my daughter is going to be so relieved to know I've got one of these.
Yes.
So it's true. All around. So it's everything that we've talked around. It is. And I, because I'm not there as a clinical person, I don't need to get into whether you would be suitable for resuscitation or not. That's not my concern, but I can give them the bigger picture. 6 people took a ReSPECT form home yesterday. They've all gone to read it. They've all gone to think about it, and they'll all be coming back in a fortnight to talk through and think about it going forward. Then they'll signpost them onto their GP to book a ReSPECT conversation.
That's the thing. It's a multidisciplinary form, which then turns into the plan.
Yes.
But the plan should be created in a multidisciplinary way, so that it may be somebody that is totally different that can actually help that person focus on what their values and fears are.
Yes.
And I think this is not a 2-minute conversation with the junior doctor at 2:00 in the morning.
Yeah.
That's not the way to do it.
Yeah.
We need, and we can't advise people as to the best treatments unless we know what they want the outcome to be. And you having those conversations and explaining that to people, that actually our starting point is, what do you want to happen at the end of that, is so important. Because I might think that X, Y, and Z is the right thing, but if somebody doesn't want those outcomes, then it's the wrong thing to do.
And just to butt in again, I just think on a practical level, because I'm also mindful that I've heard you speak on this a long time, and it's one of the things that I feel that I can do to help clinical colleagues, is that we're sitting in a sunny room having a cup, we're normalising it, but what I can say is that purple form, when you've done it, is the first thing you pick up to take to hospital or a doctor's appointment. Don't worry about the fluffy slippers or the second set of false teeth, because that is the thing you're going to be asked for first. And it just, and everybody's like, but surely they will know about it. And so I'm able to say, I know we're probably going to get onto this, I'm able to say, I don't have access to any of the systems. You need to take that form with you everywhere you go, and hopefully we're feeding from the bottom up.
We recommend that they have it on their phone, or a relative has it on their phone, so that it can be pulled up again, just like the power of attorney documents, all the important documents, so that they can at least show it to a doctor or a nurse and say, we've got one of these.
And we also recommend that they put, if they can, a copy in the message in a bottle. We give out the message bottle that goes in the fridge. We've got a client who keeps it pinned to her front door because she's multiple admissions, but that's what she wants to go. It's all that, just spreading the message to say this is not something you should be worried about. This is in your interests and your family's interests to know that you've got it.
Absolutely. And I think that involving the whole family is so important. The phone thing is particularly good because it has been known that on occasion hospitals have lost the ReSPECT plan or other health professionals. But let's say hospitals, because that's my domain. But if you can pull it up on the plan and say on the phone and say copy that out, it means people start with the information, so you're not having to revisit it again and again, particularly when you're in a rush and you might not have as much time as somebody else has had to do it. With my parents, we have 2 separate WhatsApp groups, one for mum and one for dad, with the medicines, the ReSPECT plan and anything else you need to know. And we ignore those groups, but the whole family has access to them. So I love that. The other thing, talking about this, and I'm sure we'll revisit this later, about where ReSPECT plans can be kept, and the What Matters to Me folder we've already mentioned. If you don't know about that, we'll come back to it at some other time. But I love the analogy of putting it on the fridge. That doesn't mean you have to keep it on the fridge, but if you know someone well enough that they would come into your house and make themselves a cup of tea and get the milk themselves out of the fridge, out of the plastic bottle, then they're probably somebody that needs to know about your ReSPECT plan. So that might be carers or family members. If it is somebody that you would welcome into your home but sit them in the sitting room and then bring them their cup of tea or the milk in a jug, then they probably don't need to know what's on that ReSPECT plan. But I think that's a really good idea, good way of illustrating who needs to know and maybe who you need to talk about with this. Vicki, you've been with our team about a year, and I think that meant that you came into the ReSPECT world a bit more. So I want to know what myths have been busted from you, as far as, because it's fresh in your mind. These two have heard me talk many times.
I think for me, and having the opportunity to talk with various colleagues over the last year, is me reflecting on my clinical work, because I am a physiotherapist, and the opportunities that I probably missed to start those conversations, and how it's not just end of life, it's not just a doctor's domain. And I think what Joe and Rachel, listening to what they're saying, it's having that opportunity to build a rapport with somebody and give them the time to prepare, to think about it, to talk to their family, and do it in a way that feels comfortable, in an environment that feels comfortable to them. So I think that's probably the biggest myth for me, is I could have been somebody who did that and I wasn't.
Absolutely. And you would have heard all these really important things, because I have to say therapists are much better at asking that question as to what do you want to get out of what we're going to do. And that's very much been built into your and other people's clinical practice for a lot longer than I think it has been with doctors, and I'm talking historically here.
And I think there's probably other colleagues working within the health and social care system who build rapport with people every day and have really good relationships with them, but they probably think that purple plan is not it's not, I don't understand it, or I don't feel it's for me. And I think that's what we're really trying to emphasise, is to build people's confidence into, you're probably already having those conversations, and if the person feels ready to do a ReSPECT plan, you could put some of that information down on the plan for them.
Yeah, and I think it's important that we acknowledge that a ReSPECT plan ideally will be developed over a period of time. So you will have multiple opportunities, but you don't need to complete it. And actually, a really good way to get others to start doing things is to get that purple piece of paper out, stick a label on it or write the person's name, and just add that little bit that you have to impart or that you can add to the whole conversation. And that might be, and I've been told not to mention specific departments, but I'm going to say that for some people, going to an emergency department at the moment is something they never want to do again, because it's a scary place even if you work there. It's a very scary place if you're a relative there, and it's an even more scary place if you're a patient. And that's before we get into things like dementia, which means people don't understand what's going on. So it might be that somebody imparts they never want to go to an emergency department again. And if that's the only bit that's written on that piece of paper, it will encourage others to start adding in more from a plan.
That's interesting that you say that, because actually we experience that a lot. And so one of the things we often put on the ReSPECT form is, because they're older adults, is before you admit them to the emergency department, because that's the last thing they want, can you think about all of the community services that are available? And we'll pop that on there. So think about synapsis, think about rapid response, district nurses, frailty teams. Please make ED the last option, not the first option.
Love it.
So we're not writing anything off, but we're saying think about it in a different way round.
Absolutely.
So, that, and that's the patients will say, oh, I want to be resuscitated, but I don't want to go to hospital. And we're like, well, that's not an option.
Yeah.
Let's turn it around and we also, we'll say resuscitation's many things. You might need a resuscitation of fluids, or you might need some antibiotics.
You are speaking my language.
Or you might have to go in and have an X-ray because you've got a fracture. We might need to repair that for you. But if we can do that and get you turned around and back home, then we've got a much better plan to work with. Absolutely. Rather than you just saying, I'm not going, I don't want it, end of conversation, they're frightened.
And I think that comes to some of the myths, because again, they say, well, it's about not being resuscitated. And I say, no, it's much more than that. We'd want, yes. So it's about getting the treatment that you need that's appropriate for where you are, and knowing what your wishes are going to be. It's not for me to give the clinical, but it gives the clinicians an idea of what the outcomes will be and know where you're going. So it doesn't mean that you will not be seen. But
people are so scared.
But they're really
worried.
Yes, they're really worried about being left in pain, not getting what they need. But it's just.
And I can understand that. I can understand the fear. I mean, I have experienced a 17-hour wait in ED myself. So. Yeah. And a 4-day wait on a corridor. So I can totally understand why my 89-year-old moderately to severe frail patient does not want to go into hospital. Yeah. But actually building that confidence and using the appropriate approach, getting them direct onto a ward, fills them with so much confidence
Yes.
that actually you get better outcomes
Yeah.
for them, because
Yeah.
it's the path of least resistance,
It
isn't it?
is,
in
but
the end?
and I would say on a personal thing, my 95-year-old father-in-law's just died, advanced dementia. We'd done a ReSPECT, fell and broke his hip. Off we went to another hospital in another county. Within the first hour, I was asked 5 times if he has a ReSPECT form. That county doesn't do them, but I'd done one. It was so useful to give all the wonderful clinicians there an idea of the frail, delirious gentleman on the trolley who's not my father-in-law. Actually, he didn't survive it, but what it meant was it gave him a good chance at survival. And when it became clear, we had his ReSPECT forms, and we were able to be part of that multidisciplinary team conversation about what treatment would look like. It was for my husband and my sisters-in-law, who are very much non-clinical, it helped a very difficult situation be slightly easier.
Oh, that's lovely to hear.
And that's what drives me even more.
I think that goes on then to help with your bereavement,
Doesn't it? Because it takes, and it's all those other things. It maybe takes some of the guilt, some of the worry about, were we able to support him and the team? It's very difficult for the team as well. But we'd done it 18 months ago when he was able to participate.
And I think that's the thing. I'm very
Yes.
happy having these conversations, but not all clinicians are.
No.
I think just going back to the people think they're going to be given up on.
Yeah.
I think there's also that perception sometimes when we say we won't take you to hospital.
Yes.
That makes people think they're being given up on. And this is such a great opportunity. My buzz phrase is to say, at your age and stage in life, you deserve that we should try and bring services to you rather than you schlep to A&E. And that doesn't mean I can always do it. But as you said, think of all the other options before that, because they're actually better for the patient. And most of the time when I say that phrase, the patient sort of, oh, this is not just you writing me off. And that's probably why I love a ReSPECT conversation, because the patient suddenly feels front, centre, listened to, and the right things are being done.
It is very much about adding things in as well, isn't it? Rather than just taking it, if we're not going to resuscitate, we're not going to do this. That's why I think a lot of people have a negative connotation with it, because they think it's all been taken away from me. But if you're able to say, but we could offer this instead if it's available, I think that does give them some empowerment back.
Yeah.
They've got a choice.
Unfortunately, some clinicians do start with that. And it's a horrible conversation to have. I don't like having conversations with my children where I say you can't do anything. In life, it's almost always a bargain. So if my children say I'd like to stay up and watch a horror film, I generally say, you can't stay up that late. Let's still have a seat on the sofa with the duvet, get the popcorn out, but let's watch a more age-appropriate film. So this is exactly the same idea. But in order to do that, I need to know what they're actually trying to achieve. And in that case, they're trying to achieve getting some sugar into them, not having to do their homework and having a snuggle. But I know that because I know them so well. And with all of these things, as long as if you talk to the people and find out what's in each other's minds, the most important things in life become easier, and we're all much happier with them, and they're a better experience.
And also, Rachel, I don't know, for all of you, I think, certainly the people that we're supporting and talk to, these are realistic older people. They're living a very challenging period of their life. They're caring for somebody in difficult circumstances. Actually, the vast majority know that they are probably entering the last phase of their life. The vast majority want to get their affairs in order. That's where they're coming to see people like me or you. And the vast majority are very grateful that we're willing to have a pretty honest conversation. Lady said to me yesterday, Jo, she said, don't worry, I'm not squeamish about this. I want to talk about it. I'm going to take the form away and I feel so much better already. that's a great start.
Do you think there are people who think, I don't want to start that conversation
Yes,
because
I do.
the patient doesn't want to hear it?
And I think we do, Vicky, but you and I have also talked about this too. I think it comes down to the confidence of the person also, because there is always that when we're all seeing, although we know some of our clients really well, we don't know them that well in reality. There is always that little anxiety about, I don't know where this conversation might go, and I don't know if I'm going to get myself into a difficulty that I can't answer, and I'm going to make it more difficult, not easier for the person. And that's all about the confidence of the person having the conversation. I run through the conversations that I've heard Tanya have. I unashamedly plagiarise some of them because there's some jolly useful phrases in there. But it is also about that confidence of and I think just being in yourself confident enough to say, I don't know all the answers, but I've got one because I know when the time comes what I don't want. And as I say, I very much frame it, well, I might say this, what I say to my children who won't yet have one, but they're all early 40s, is that there's 4 things you need to have in life. You need to join a union. You need to know where your external main stopcock is. You need power of attorney form, and you need a ReSPECT form, because by the time you need any one of those 4, it's too late. I thought about that after one of the boys phoned us when his flat was flooding and he couldn't turn it off. And actually, I can't talk in depth about unions. I certainly don't know anything about stopcocks. But it's enough just to raise that awareness. And that's sort of where I'm coming from when I'm talking to the people I'm supporting in the community. Let's plan for the worst and hope for the best. And then their shoulders go down and they've got something to work around.
Do you do anything in your roles, any of you, to prepare them for the conversation? Is there things that you...
Is that with staff or
well,
patients?
Probably with staff. That could probably be done both ways, really.
Yeah, so in my team, there's myself and another matron, and we've got 2 assistants. One's a retired paramedic, one's done 20 years on the district as a HCA. I think we've got about 150 years worth of experience all told. But every single one of those people are confident to have the ReSPECT form because we support each other. And, I'll have community nurses who will say, oh, that patient needs a ReSPECT form, but they're on the Gold Standards Framework Register and they're providing palliative care. And I'm like, well, do one then. I can't possibly do one. I can't do one. It's the doctor's job. Or can you do it? I think that's a shame. I think that's a missed opportunity because more junior staff coming into the community now don't have that confidence. We used to have the Sue Ryder days where we'd go up and we'd have the advanced care planning conversations and the confidence building. I'm not sure that happens anymore. So we get people that are seeing these patients that need to have these conversations who are too scared to have them. So you're right, it is about confidence building, and it starts at the bottom and then it works its way up.
Yeah. Presumably it's a thing that you don't get better unless you do it.
That's
more
right.
frequently and
I would
reflect
say,
on it. And
I would say that each conversation's unique. People are different. Some people will be really willing and open to have that conversation, and some people are going to be a lot more guarded. And as you say, it's just starting it. It's just, for us, a lot of the people we see are post-discharge. So we'll say, tell me about your admission. What did that feel like?
Yeah.
And what do you want to happen next time?
Yeah. I think that's the way I start the conversation. There's lots of people who don't want to talk about emergencies. And, we live in a world where talking about bad things, we believe it'll make them happen. We're all a wee bit superstitious. But actually, most human beings quite like talking about themselves. And that's the way I start it. So I don't give any warning shot that we're going to do a ReSPECT conversation. I do the way that actually I do my consultations, which is tell me what makes life good for you and tell me what I need you to have achieved, be able to achieve with whatever I do. And that might be stop the pain. It might be get me to, make sure I can attend my daughter's wedding and walk her down the aisle. And I think that's what therapists are good at. But after I've really heard what matters to them, you then get an idea of how to progress the rest of the conversation. And at that point, it might be, do you know what? This is really important that I put this on this purple piece of paper because I'm not sure people would always guess that about you. And as a result of that, we can make sure that they do the right things for you. But I think whenever you're starting the conversation, if you make it very clear that you're interested in this person as an individual and you want to know why they don't just fit on the conveyor belt, because most of us don't, I think you've then got a really good relationship because they realise what's important to you.
I think it's also important to say that sometimes you might have to revisit that conversation several times because you start it, but they aren't genuinely are not ready. Mm. And, I've coded that on the summary care record and I've coded ReSPECT and I've put in there, does not have a ReSPECT form, have tried several attempts, just cannot have this patient to have the conversation. And there is that ReSPECT around the therapeutic relationship.
Yeah.
And you might be needing to do lots of other things with them. And if that is creating a barrier, then you just have to park it and let somebody else have a go. And ultimately, we will always try and do the best for our patients. It's always better if we know.
Absolutely. I think, though, people can just be scared of the purple piece of paper. What I would say is that as a confident and fairly competent emergency clinician, if I have a ReSPECT plan and all that person's been comfortable writing down is what they value and fear and nothing else, with a couple of facts at the beginning of it, so that I love a clinical frailty score on the summary because it just sort of gives me a big idea of what that person's managing to do. But I don't actually particularly like lots of medical conditions written down there because I can normally get those off a computer somewhere. But knowing that they live in a house with a spiral staircase or that they've got a really supportive neighbour and that actually they're housebound, so I'm never going to get them running a marathon, really gives somebody colour in my mind. And that's particularly important if somebody comes to an emergency department because nobody looks their best when they come to the emergency department. You're feeling ill, you haven't done your makeup, all the rest of it. So you can get the wrong impression of somebody in both ways. So having a picture is really great. And I always say, if I know what the situation is and what that person really values in life, I can probably use my medical knowledge to work out what they need. If somebody has just written medical guidance on the plan but haven't told me what matters to that person, I'm never going to be able to work it out from the clinical guidance. And it might be that they can't put it on a purple piece of paper. It might be that we write those values and what matters to the person somewhere else, and the whole sharing notes is a different issue. But even if we can't write it down and share it, by starting that conversation, they've thought about what matters to them. And it might be that their dog's the really big priority and they feel empowered enough to say, I don't want to go to hospital because nobody's going to look after my dog. And at least if they've had a chance to think about that and been asked about that and realised that healthcare professionals still want to know about that stuff as well as everything else, then it can help them say what matters to them. And it helps break down those barriers that, you can't tell the doctor the other stuff. So I think just starting that conversation is so important. I'm aware that I could talk about this for days, weeks, months, and I do. Anybody who's met me knows that. But I'm also very aware that I can be a bit flitty. So I think what we've talked about is how to start that conversation and a bit about what the ReSPECT process is, and hopefully busted a couple of myths for people about what the ReSPECT conversation and plan is and what the most important bits are on that ReSPECT plan. Is that right?
I would agree.
I think
Ace. So I want to take this opportunity to thank you all for your time. And I love talking about this, but we may well see some of you again on future episodes. But I hope we've got people interested, and maybe people that are listening are thinking, oh, I didn't realise quite that is the focus. So if so, or if not, come back and see if we can surprise you with some information next time. Thank you. Bye.